to measure HER2 status, including two that are of interest, namely the so-called HER-Mark dimerization assay and the measurement of HER2 status in circulating tumor cells. The HER-Mark test, I don't have any slides. It's a very, very early development test. It's fully commercialized. There are sales representatives attempting to market it and sell it as a way to do HER2, claim that it's better than either FISH or IHC based on one study presented at last December San Antonio Breast Cancer Symposium. They now do finally have a full-length manuscript that's been published, but there's very limited data. It's not prospective. It's not randomized. And it's possibly a very good test, but it's not validated, in my opinion, to a level where I would stop doing my own FDA-approved method and mail my specimen to a central CLIA-only approved laboratory to do their method that I don't know about instead, at least not at this time. I'm sure you've probably all already heard there's a lot of marketing of this going on.
Is KISH validated?
KISH is FDA approved at the same level as FISH. Pre-market approved for selection of patients. It's not in the trastuzumab label, but it has the same level of approval, meaning pre-market approval, PMA, for selection of patients as eligible to receive trastuzumab. Yes, they have to. It's FDA approved. It's equal in its ability, but the only thing about being in the label is Genentech cannot market it if it's not in its label. PathVision FISH is in the label. DACO Hercept test is in the label. But KISH, they can't say anything about, but it's FDA approved, and there would be no way that CMS could deny payment for trastuzumab because the patient's only test was their FDA-approved KISH test. They would never do that. It's just as good as IHC or FISH according to the standard of the FDA. Good. So that's one. The other one is, and we'll talk about, is measuring them in circulating tumor cells in a moment. A couple of other comments. I think we're getting close to the point where we'll want to take a break. A few more minutes and we'll take a break. Yeah. Maybe we can finish breast cancer. That'd be great. Markers of prediction of resistance to trastuzumab, which came up before about truncated. One of the thought about truncated and shedding of the HER2 protein, that has not been validated as a predictor of resistance to trastuzumab. The high HER2 copy number versus low, we thought for sure you got more than 10 copies, much less better chance you'll get a benefit than if you've only got 7 or 6 copies. It hasn't worked out very well. So we can't say because you have a low amplification, you're less likely to benefit than if you have a high one. Just isn't enough data to prove it one way or the other. We talked about the dimerization status. I list it still as not validated. One that's of been interest to me is instead of going at the tumor cells, go at the person's genome. Go at her germline and try to decide whether or not she has a normal immune system or possibly a polymorphism in the Fc gamma receptor that interferes with her ability to mount an antibody-dependent cellular cytotoxicity response, an ADCC. There's good evidence in the rituximab literature that women with Fc polymorphisms don't benefit from rituximab. And apparently, I learned today that companies are designing different types of rituximab to overcome in that subset of patients with the polymorphism their inability to get an ADCC. But for trastuzumab, the data is very new. But there is some preliminary data that patients who have this certain polymorphism that makes them unable to make an ADCC won't get anywhere near the benefit from trastuzumab as a patient who gets a robust ADCC when the antibody is used. So I think that test has potential. The PTEN deficiency affecting the activation of the PI3 kinase pathway is a very validated marker, but it's just extremely common to find it, and it's hard to use it clinically. But most people feel that we could do PTEN staining on breast cancer, and if it was absent, predict more of a chance the patient won't benefit. Remembering always that trastuzumab is rarely given as a single agent. It's usually combined with other cytotoxic chemotherapy, platinum-based, taxane-based, maybe anthracycline-based. And sometimes you wonder, are we really looking for resistance to the antibody, or are we looking for resistance to the companion cytotoxic? So it's hard to do the work because you're not using it as a single agent. And I have a whole bunch of others less. I'm very interested in the IGF-1R, the insulin-like growth factor receptor 1R overexpression. I think that has good promise as a possible predictor. Looking for phosphorylation of the HER2 receptor has gotten some significant interest in enhanced response in one study, and there are a group that are working hard on that one. Some others, the TOPO2, well, what can we say about TOPO2 alpha? I'll say it in a moment. It's kind of the test we've been waiting for, and one other emerging test is microRNA-based predictors of resistance, but again, they're very early and not validated. A couple comments about HER2 expression in breast pathology. One of the best HER2 tests is a physical examination. If your patient has Paget's disease of the nipple, she's HER2 positive. If the test comes back negative, question whether it's a false negative test result. The Paget's disease reflects mobility and motility of breast cancer cells. The HER2 protein on the surface appears to impart in all types of experimental models, cell lines placed on an electrical grid. If you put them under a current, the HER2 positive cells will move much farther than the HER2 negatives will. So the overexpression on the membrane seems to give cells an ability to move farther. And what's Paget's disease? The migration of the cancer cells out onto the nipple epidermis. And I did a case for you here to show that. Here's a robust 3+ IHC. Here's the epidermis of the nipple here. Here's the dermis below. And look at all of these HER2 positive breast cancer cells in the classic Paget's distribution, showing robust 3+ positivity. So truly, you don't need to do HER2 test. Well, you do need to do it, but you can predict a HER2 positive and question a negative whenever you have a Paget's disease. A couple of other last comments. Invasive lobular is almost never HER2 positive, only the pleomorphic subtype and at a low level. Mucinous, medullary, papillary, tubular, those are all HER2 negative. But we have no option not to test. The NCCN guidelines are all newly invasive breast cancers will be tested for HER2. So even if we know we're dealing with a pure mucinous or a pure medullary and the test's going to be negative, we're still obligated to do the test. And we don't want to deviate from that standard because we don't want the patient being treated below the standard by the oncologist who's taking care of the patient. BRCA1 positive mutation germline patients have a much lower HER2 positive rate than wild type. It's not known exactly why, but you'll never see double-digit HER2 positivity, and some say it's only in the 3 to 4% range of BRCA1s are positive. Compared to DCIS, we already talked to about 20 to 30% alone in all comers, but it's much enriched if you look at the high-risk, high-grade ones. Breast sarcoma is negative, male breast cancer, somewhat all over the place. And one last comment and we'll break, is proliferative lesions of the breast that were biopsied and found not to be malignant. No in situ or invasive cancer, maybe with a little atypia in the ductal hyperplasia, but HER2 positive at a low level, a 2+ stain or a low level mRNA, compared to the